series of the EP Club. And in this session, GJ will be speaking about the long RP tachycardia. He is from Abbott, and this is one of the most difficult when coming for diagnosis point of view. And the diagnostic dilemma is when it is a short RP, everything is very clear. But when in the long RP, the differential diagnosis as well as the protocols are totally different. So over to GJ for the next.
Thank you, GJ. Thank you, sir. Good morning. Today we are going to talk about long RP tachycardia and how to diagnose in ECG as well as EGM, and then how to interpret in EGMs with a diagnosis maneuver in a EP lab. So this, what is long RP tachycardia? What is RP? Is it possible to see in sinus rhythm? So RP means a supraventricular tachycardia with a longer or shorter RP interval than PR interval on ECG. Can be differentiated from other SVTs by understanding the underlying mechanisms and ECG patterns. So this, it's not possible to see in sinus rhythm. So this, it is possible to see in only in SVT, supraventricular tachycardia. Next slide, I'm going to talk about what is short and what is long. So this is two ECGs. The first one is short RP tachycardia and the second one is long RP tachycardia. That blue arrow which indicates is R wave, and then again second blue arrow which indicates P wave. So this is a R wave and this is a P wave. This R is first and retrogradely there is a P waves. So this R to this P, the interval is very short. So this is short RP tachycardia. So that's the same thing, it will happen here also, but there is no R here. So we need to look the first R wave. So this is a R wave, and then second P wave is here. So this is very long compared to that first one. So this is a short RP tachycardia. There is a cycle length, that means there is a milliseconds will be there. Short RP tachycardia is less than 70 to 70 milliseconds is short RP tachycardia. R to P interval is less than 70 milliseconds, and long RP tachycardia more than 70 milliseconds is long RP tachycardia. So this how to demonstrate SVT with RP interval. So this RP interval we can demonstrate with the RP interval only. So this RP interval, what I said prior to the slides, less than 70 milliseconds is short RP tachycardia, mostly AVNRTs, mostly P waves sometimes we cannot able to see, it will buried with the QRS complex, that's AVNRT, and RP longer than 70 milliseconds, that is having a differential diagnosis of multiple. One, it is atrial tachycardia, there may be a chances, and then atypical AVNRT, sinus tachycardia, sinus node re-entry tachycardia, inappropriate sinus tachycardia, and then PJRT. So these are the differential diagnosis of long RP tachycardia. So this we need to keep it in mind. It is a long RP tachycardia. We need to keep it in the mind of atypical AVNRT also, atrial tachycardia also, or sinus tachycardia also. And next slide, I'm going to go with the quiz, and this is short or long. I need to go with the quiz. So this blue arrow which indicates some clue, you see in lead 2 and V1 only we will see P waves. Here that V1 we cannot able to see properly. You see this lead 2, here there is a P waves is there, that blue arrow shows P wave. So if we take this as a R wave and this as a P wave, so it's more than the small boxes, it's more than 200 milliseconds. So it shows more than 160, 170 milliseconds, R to P interval. So this is a short RP tachycardia. And next, anything, sir? Long RP, sorry, sir. Thank you for correcting me. It's a long RP tachycardia. And this one is another ECG example. And this is a ECG example. Same, we are going to see lead 2 and lead 3 and V1. V1 also having P wave, and lead 3 also we are able to see P wave, and lead 2 also we can able to see P wave. So here that more prominent P waves which is seen in lead 3. So this is a lead 3. If you take this as a R wave, and there is only very small 3 boxes, it's less than 60 milliseconds only that RP interval. So we need to calculate that small boxes is 0.02 milliseconds, that means 20 milliseconds. So if we calculate, that is only 3 boxes is coming into that area. So this RP interval is less than 70 milliseconds. This is a short RP tachycardia, most likely to be a AVNRT. So this is a diagnosis part of short and long RP tachycardia according to ECGs. So there's other ways we can find it is QRS, electrical utterance, rate, age, these kind of things it will change patient to patient, but ECG wise this is a easiest formula to find short or long RP tachycardia. Next we are going to in EP lab how to diagnose the AVRT, AVNRT and AT. So this is nothing but short RP or long RP tachycardia. We are going to do with the differential diagnosis methods. One, it is EGM's activation. Second, PVC during his refractory period. Third, entrainment pacing. And fourth, it's PVC, or else if the patient having intermittent pre-excitation, we can give adenosine and we can check the patient having that pathway or not. Fifth is para-Asian pacing. So these three we will usually do with the very rare cases. Last two, first three we are doing in a regular basis. We are doing in all EP labs. Last two, if that para-Asian pacing, if the patient is having anteroseptal or para-Asian pathway or mid-septal pathway in orthodromic AVRT cases, we can doing this. And this is if patient is having any kind of intermittent pre-excitation or we cannot able to diagnose it. So this we are going with the pharmacologically, we can blocking the node and we are seeing the pathway is there or not. So this next slide, I'm going with the EGM activation. The first EGM activation is V pace. So this is V pace and this is sinus rhythm. You see the first is HRA and HIS and CS and RV. So this is our usually we will keep it in our EP lab. So this first we paced at V so that it has to go to node only. That means HIS only has to be first as a normal activation. Now you see that is CS distal is first. So this it shows that is there is a pathway conduction is there. That means it is kind of a long RP tachycardia or else AVRT we can go ahead with. And second ECG, this is a patient having the pre-excitation, that means manifest pathway conduction. How we are seeing manifest pathway conduction? Your ECG same, CS 910 is early and then 12 is late and his catheter is also separated. So there is a delta waves in the ECGs. So this we are easily able to tell this is also a pathway conduction, no AVNRT. Next, his sync PVCs. So this is a very, very important step in all SVTs. That is all basic maneuvers while pacing. V pace we are checked. There is retrograde conductions we are checking and eccentric concentric. This is sinus rhythm. So this once tachy is induced, how to differentiate? That means this is the first foremost one it will come into our mind. One, it is hissing PVCs. Hissing PVCs is nothing but if the tachycycle length is going at 280 milliseconds, we need to give one PVC in RV with the less than 30 milliseconds. Example, less than 30 or 20 milliseconds. 280 means we can give a PVC at 260 milliseconds. It has to hiss refractory and it has to go there. So this example, if SVT terminates with the PVC, if you are giving that PVC, it is terminated. So there's that assumption of accessory pathway is present. So this as of now we are going with the neglution only. Next, did we change the AA? If A to A is pulled and there is a assessment of pathway is there, 100% there is a pathway. There is no A to A change. There is ruled out of accessory pathway and it may be AT or maybe a AVNRT, most likely to be AVNRT. Delay in the AA, same. It's pulled or delayed, there may be a accessory pathway present. And next, this is an example of paced PVCs during his refractory. So this is a his catheter. We are given PVC and you see that ECG morphology change. There is a PVC and you can easily say this is a HR catheter. 335 milliseconds is a tachycycle length is going. We are given hissing PVC at 315, 20 millisecond less than we are given. You see that A to A is pulled. 335 to 320, around 15 milliseconds it's pulled, so that there is accessory pathway may present. Next, we are going to entrainment pacing. This is very, very important step. Entrainment pacing maneuver is used to diagnose and locate the circuit involved in the re-entry tachycardia. This entrainment pacing will helpful only in re-entry tachycardias. In focal tachycardias, it may not helpful. So what are the steps we need to do? If same kind of a PVC thing, pacing at faster rate, resetting the tachycardia, post-pacing sustainability of tachycardia, and identifying the circuit. So these 4 steps only we are going to always we are following. Example, 280 milliseconds of tachycardia cycle length, you are going to pace at 260 milliseconds. Fasterly you are pacing and resetting the tachycardia. It's entrained or not. Second, post pacing sustainability of tachycardia. After stop pacing, the tachy has to persist. Third, and you need to measure that PPA minus TCL cycle length, and we need to confirm the tachycardia is within the circuit or outside the circuit. So this is our normal diagram of entrainment. You see, this is a tachycardia is going, and we are giving a stimulus, and it is coming into the path, and it is resetting the tachycardia, and this is reset is entraining, and it is resetted, and it is termination. So this is just a basic diagram. You just remember it, and I am going with a calculation, and you will further understand entrainment more. So this is an entrainment. So this tachycardia cycle length is around 467 milliseconds, and we are paced at 450 milliseconds. So this, if you see, once I stop the pace, the tachy is persisted, and then same that pacing cycle length is I paced at 430 milliseconds. So this, if what we are going to measure is post pacing interval. After that, we are minusing the tachycardia cycle length. So this how much it is coming. So this tachycardia is 467 milliseconds. PPA is 528 milliseconds. So this we are minusing this 467. My 528 minus 467, it is 61 milliseconds. So this is favor of AVRT, that is long RP tachycardia. This is favor of long RP tachycardia. So this next is AH with corrected PPA minus TCL. This is little bit complicated. We need to understand, and then that how we can understand is PPA minus TCL minus baseline AH minus AH of paced AH. So this we need to minus, and we need to calculate the value. This is little complicated. So usually we will go with the PPA minus TCL value is 95%. That will be a specificity. And normal values of entrainment pacing, one it is PPA minus TCL less than 110 milliseconds, more than 110 milliseconds, that is AVNRT, less than 110 milliseconds, that is AVRT. Some occasions, that is in the left lateral accessory pathways, it may have a possible of more than 110 milliseconds, because we are pacing from right ventricle. So the circuit is very out, and that other circuit is going from other side. So this AH corrected PPA minus TCL, AVRT less than 80 milliseconds, AVNRT more than 80 milliseconds. So there's other things also it will be there. That is entrainment response. Sorry, I'm not added in this. That is entrainment response. One, it is if it is VAAV response, that is AT, VAAV response, that is AVNRT bar AVRT. I will show you it in the next slides. What is VA and AV? So this is our basic understanding I have taken from our normal slide. So this is tachycardia is running at the cycle length of 380. We paced at 360. You see, this is a pacing spike. It is captured, and it is reset at the tachycardia. You see, A to A cycle length also changed 360. And post PPA minus TCL is 477 milliseconds. So this, if you minus tachycardia, it is more than 110 milliseconds is coming. It's most likely to be a AVNRT. So this clue of orange arrow, which I mean to say, is V, A, and V. So this is a VAV response. This is excluded atrial tachycardia. You can able to understand. I will show another VAAV response if it is there. Means this is a VAV response. So this it's a reentrant tachycardia, maybe AVRT or AVNRT. So that we are measured, and we got PPA minus TCL more than 110 milliseconds. So this it's going to the favor of AVNRT. So this next is para-Gaussian pacing. How to identify para-Gaussian pacing? I am not going little bit deep. This little bit complicated. Yeah, I'm just going. So this, thank you very much, sir. Thank you for giving this opportunity.
So Gijendra has given a lot of insight regarding the long RP, but what are the challenges? I will just, in his own slide, I will just give some brief review on the topic. So the diagnostic point of differential diagnosis, whenever the long RP, when we are saying it is either atrial tachycardia, atypical, these are the two very difficult to diagnose. And third comes the PJRT. These are the three diagnoses we are always giving. PJRT means permanent. This is not a permanent. Basically, it is a what you call what you call slow conducting pathways, which is usually posteriorly designed. So, uh, in this type of tachycardia, the tachycardia will be very incessant. Means small one beat and it will start going. So, I'm just missing the word. So these three are the most important. The PJRT is a pathway. Atypical AVNRT is a variant of AVNRT, and atrial tachycardia is a focal tachycardia. All are having different mechanism. So atrial tachycardia is a focal. So you huh? Permanent. Yeah. So in this there are two are re-entrant. Atypical AVNRT and PJRT. The main challenge is between the atrial tachycardia, AVNRT is you can just, if you are having 3D system, you can do and come out, because there you will be knowing there is a focal and is a re-entrant and the locus is different. But when it comes for the AVNRT, atypical versus PJRT, it is becoming difficult. So how we are going to differentiate it? Because in PJRT, the tachycardia, the circuit is ventricle is the part of the circuit. While in atypical AVNRT, it is not the part of the circuit. So when you are giving a his refractory VPC and it is what you call pulling, it goes in favor of PJRT. If it is not, AVNRT. So whenever atypical AVNRT, what we are having three maneuvers we are going to do. First is we have to, if we are able to dissociate the ventricle by pacing, the tachycardia is ongoing and we have dissociated, it is atrial tachycardia. If it is not able to dissociate, still we are having three possibilities. In that, if we are able to PPI TCL, if we are going and we are getting the suppressive response, means when we are pacing, we have entrained, and when we are stopping, it is VAAV, then it is a atrial tachycardia. If it is VAV, then it is a AVNRT versus atypical AVNRT, PJRT. And then differentiation will be just put his refractory VPC. If it is pulling or pushing, either of the things, it will go in the favor of PJRT, and otherwise it will be AVNRT. So this is the basic difference. Sinus tachycardia, sinus nodal reentry, it is difficult. It is only and only by the mapping we are able to differentiate it. Sinus nodal reentry tachycardia, the one response what we will be getting is that when we are giving when we will be giving isoprene, all of a sudden it will pick up because the circuit is in and around the SA node. It will go and it will come down. So that is the one reason. Sinus nodal, the difference will be this: it will slowly going up and slowly going down. The warm up and cool down phase will be there in the sinus. But sinus nodal re-entry, it will be, since the sinus node and the tissue in between, there is a circuit has been created. So there is a slow and fast, again like a AVNRT, the same thing is going on, but it is a the what you call, all of a sudden it will be, means sudden onset and sudden offsets will be there. So this is regarding the whole differential diagnosis when we are approaching. The second part regarding the what you call short RP versus long RP, how to classify. What he has told, it is regarding 70 millimeter is the definition what we use. That if septal VA, means if we are seeing the surface V and his A, if it is less than 70, sometimes it is using 60 also. It means the activation of atrial ventricle is happening parallel. If we are able to show that it is more than 70 millicurie, it is not a parallel, then we have to show it may be a atria followed by ventricle-like activation. So parallel activation, until proved otherwise, it is AVNRT. So whenever we are able to show that septal VA is more than less than 70, we are having differential diagnosis only one, that is AVNRT. So that part is over. Why short RP less than 70? Short RP less than 70, AVNRT. Short RP more than 70, we are having AVNRT, AVRT, anything can be possible. So, and now coming to the long RP. So long RP versus short RP, the definition is when RP, R to P is more than half of the RR interval, then it is a long RP. Sometimes we use short RP, intermediate RP, long RP also. But as an intermediate word is not been used in the literature. The short RP, anything within the half of this one, it is short RP. Less than 70, it is taken as a very short and it is diagnostic of AVNRT. If it is long, it can be atypical AVNRT, PJRT, atrial tachycardia. So Less than 70 is less than 70 millisecond short RP is AVNRT, but long means more than RR interval, half of the RR interval. And I think in this, most of the things he has covered, and this is very important. The slide, what I find that we always advance pulling word we are using, pull kar raha hai. So this pulling word means advancing it. So it is a diagnostic of what you call accessory pathway, but in bystander also it can be possible. But if you are able to push it, means in place of pulling it, if it is pushing, it is diagnostic that it is involved. It is not a bystander. It is not possible. So this is the main difference between the pulling versus pushing. If you are pulling it, it can be bystander and it can be involved. Either of the things is there. But if it is pushing, it is always involved. It is the pathway is the part of the circuit. And I think in this, most of the things has been covered. So nothing more to tell. And I think we are running short of time. So thank you so much for a wonderful class. And lastly, today's any questions from? If you are not asking question, I will ask the question from the audience. Are you ready? Koti, long RP क्या है? Tell me what is long RP. पूरी long RP class में what are the differential diagnosis? Greater than